Today we have part 2 of sodium. Today is gonna be a little bit easier because the hard part was last week. Uh, Good news is there will be no calculation today because I already give you everything you need. I saved you some trouble from calculating stuff. So let's go on the first case.
Okay, hold on.
And we have 2 people. Each
Yeah.
of them gonna read one case, I guess.
Oh my God, where's Vong? Maybe
Oh
the
yes, where's
internet.
Vong?
Yeah, maybe she's.
All right, I guess we wait a little.
Yeah, she's just okay. She's joining.
Where's my?
So the last week we have the very useful topic about sodium disorder, right? So I believe you guys can learn a lot of things from that. So how you think about this part today? I mean, like after you have time to prepare, do you feel like you feel more easy? Sorry, you feel easier to make the answer for those questions today? How you think? When
Mm, I think that about this topic is very interesting because it relates to kind of many departments.
sure.
And yeah, it's very important for us to know about how it works. And about this week, yeah, like Mr. Leon said, it's a bit, we can say that it's a bit easier than the last week because we have chance to prepare for it. For last week and also for this week.
Yeah.
And yeah,
This week should be very easy because
but it's still
technically,
interesting, I think.
We just
last week was tough because you have to calculate all sorts of things. But normally in the hospital you don't have to because when you order a lab, they already did that for you. On the lab page, they already have serum osmolality, urine sodium, everything. You can just look at it. That's why I like being a doctor and I don't have to do math. I mean, sometimes I do, but like you know about it when I talk about calcium, you still have to do a little bit of math.
Mm-hmm. Yeah.
Calcium is harder, but calcium is not
Yeah.
that bad. Easier than sodium for sure. So let's have one read the first case. What is long joining?
Yeah.
So let me read it first.
Yes.
Yes,
Please.
let's read it.
A 45 years old woman presents to her primary care physician for persistent thirst. She has a past medical history of bipolar disorder and hypertension.
Bipolar. Sorry. Bipolar, not bipolar. Bipolar.
Bipolar.
Bipolar disorder and hypertension. And she reports that the thirst began 4 weeks ago, along with increased trips to the bathroom. Her young cousin was recently diagnosed with the diabetes after similar symptoms, and she immediately she has diabetes. On physical exam, she has revealed the following: sodium is 150, urine osmolarity is 100, and serum osmolarity is 30/95. Urine osmolarity remain untreated after administration of vasopressin. What is the most likely diagnosis? Insulin resistant, central diabetes insipidus, uh, nephrogenic diabetes insipidus, primary polydipsia, and chronic kidney disease.
Good job. It's not a tough case, so let's analyze the case again, like what we do every day. Couple of questions that I want you guys to keep in mind: signs and symptoms, age, acute or chronic, and is there anything that concerning that pointing out to you? So let's analyze it. So who want to tell me what's important?
It's the it's a bit kind of chronic disease because it belongs for 4 weeks and
Okay, that's good. 4 weeks
Mhm.
ago.
and she just have only symptom of persistent thirst and kind of dry mucous membrane.
Okay, so she dry.
Yeah, and
Mhm.
she go to the bathroom, increase the times of going to the bathroom for kind
Can
of
see, yeah.
yeah.
Okay, that's good. What about her lab values? Anything concerning?
She has um high high concentration of sodium.
Okay, so
Yeah,
hypernatremia.
Hypernatremia. Yeah, you should say.
hypernatremia,
What else?
and the um hypertonic
So,
osmolarity, high
so
osmolarity. Yeah.
high serum osmolality, right? What's the normal that we talked about last week? That you gotta all
It's
calculate and compare to.
280, right?
Yeah, around that. But technically, in this case, it's just high. Okay.
Yeah. hmm And
What else?
the water deprivation test and the administration of vasopressin review the untrained in the urine osmolarity.
Good. What does that
Mhm.
tell you?
Um,
I mean, that's important, right?
yeah,
What vasopressin? Let me ask first. What's vasopressin?
88, 88
It's
almost.
ADH, right? So what ADH do? Remember the time where we draw the nephron? Remember that? What's ADH do?
Yeah, it provides our renal tube to kind of reabsorb water.
Okay, good, good. So ADH help reabsorb water, right?
Yeah.
Cool. So what else? Does she have any medical history that concerning you?
She has a past medical history of bipolar disorder and hypertension,
Okay.
and she has a precaution with diabetes.
Okay.
Yeah.
So what's bipolar? What do you think? Well, if she chronic bipolar, she should have some medication, right?
Yeah.
All right.
Yes.
Well, she definitely takes something that may cause this, but I won't ask you about that right now. So tell me how you interpret the water deprivation test.
Yeah, the water deprivation test, we often order it in the patient with kind of polyuria to
Okay.
differentiate um, the the reasons for the polydipsia, like it
That's
is
a very good point. All right. So
yeah.
polyuria is when we concerning about there's three conditions that may cause polyuria.
Mhm,
There's more though, but there's three most common condition,
mhm,
which is all in there right there on the question choices.
Mhm.
Primary polydipsia, central diabetes insipidus, and nephrogenic diabetes insipidus. And the water deprivation test and vasopressure will tell the difference.
yeah.
Okay. Why we don't use the algorithm? Because patients not have hyponatremia, of course. This is hypernatremia. Okay. All right. So what do you think the patient has based on the water deprivation test and administration of vasopressin? So
Um,
What's insulin resistant?
So this patient have the unchanged urine osmolarity
Uh-huh.
after the deprivation test. It means that it's not the kind of psychology um, reason,
Okay.
organic reason, yeah. And the untrained in the urine osmolality after the vasopressin test, it tracks the reasons from the it,
So, uh, let's ask you this question. Let's go to each answer choices and see if the water deprivation test and vasopressin make anything changes, okay? So let's ignore all the number in the question because we know she hyponatremia, her high serum osmolality and polyuria, so all the numbers just tell us that. But to analyze the diagnosis, we have to get the water deprivation test and vasopressin test understood first. So let's go A. What's insulin resistant? Is that gonna affect your water or something? What insulin resistance?
it will have to increase the concentration of glucose, right?
Does insulin resistance cause a change in sodiums or what? It could cause it, but it should be unrelated to the nephron because it really technically insulin resistant is type 2 diabetes. Okay, if you have insulin resistant, you're type 2 diabetes. Type 2 diabetes patient very similar to diabetes insipidus. Patient have polyuria, polydipsia. There's one more poly, I forgot what's that. But technically they pee a lot, they hungry all the time, and they drink a lot of water, so very similar. But if patient have type 2 diabetes, usually they have disorder related to potassium instead, because insulin affect potassium channels. So I don't mention anything about potassium in the case, so you should know that potassium is normal. Okay, there's not a lot of things that can affect potassium, but type 2 diabetes affect potassium more than sodium. I wouldn't say that they not affect sodium, but they don't change the sodium that much. They probably cause hypernatremia as well because the patient pee a lot, but usually the potassium is the one that concern. Also, is cause acidosis. It's one of the cause of metabolic acidosis. One of the mud pie disease. If you know the mnemonic. Okay, so we can cross out A. What about chronic kidney disease? If patient have chronic kidney disease, what do you think about the value? So if patient have chronic kidney disease, the thing that change the most should be calcium. Okay, we'll talk about it next week when we talk about calcium in chronic kidney disease. Usually we can tell the difference because calcium in chronic kidney disease, just the lab value. Okay, there's a lot of signs and symptoms for chronic kidney disease, but like urea can also be changed, and calcium is the most noticeable in chronic kidney disease. Not sodium though. Sodium doesn't change a lot with chronic kidney disease. Okay, so now left us with 3 choices. Now let's see if the water deprivation test change anything on this. So central diabetes insipidus and nephrogenic diabetes insipidus, what are those? We need to tell the difference first. We need to understand the disease first before we talk about the lab. So you guys already learned those in school?
Yeah.
Good job.
Vâng, any question? You look confused.
So I can understand what you say.
Okay, did you learn about central diabetes insipidus and nephrogenic diabetes insipidus?
Not yet, but I think that I will learn about it soon.
Okay. So it technically, well, I let Nguyen explain it. Seems like she knows it. Let she explain it.
Yeah. Um, it's it's different into the root of the diabetes insipidus. With the center diabetes, the cause of the polydipsia is from the plate that produce the ADH. It is the hypo. I'm sorry.
So you go on the right track, but let me help you. What's
Yeah.
central? What's central mean? Let's just analyze the word first. Central mean the brain,
Yes.
okay? And
Yeah.
nephrogenics means in the nephron, okay?
Yeah.
So the name tell you where the problem is. So in both of the disease related to ADH, okay? One of them is under secretion of ADH or no secretion. What do you think it is? Where's ADH produced? In the brain, right? Pituitary or anterior pituitary? Posterior pituitary or anterior pituitary? Well, you know anatomy. Do you know where ADH is secrete?
The posterior, the
Posterior pituitary, right?
yeah,
So, what happened if the posterior pituitary not working?
when it doesn't working, it can secrete the ADH and
So it cannot secrete ADH.
Yep.
Right. Do you think it's central or nephrogenic?
I'm sorry.
Do you think if the posterior pituitary cannot secrete ADH, do you think the problem is central or nephrogenic?
In this case, right?
No, let's not talk about this guy. I'm just asking you a question about the disease. So you say that the posterior pituitary, if it's damaged, it cannot secrete ADH, right?
Yes.
So do you think that problem is central or peripheral problem?
It's a central.
So central diabetes insipidus is something happened to the posterior pituitary that it cannot secrete ADH, or it doesn't have the mean to do so. It could be completely fine, but it just doesn't secrete ADH.
Sorry.
Nephrogenic diabetes insipidus.
Sorry.
Yes.
About the production of ADH is from the pituitary or the hypothalamus.
Yeah.
Um,
That's true.
The
But
secretion of ADH
the
from posterior
secretion is
pituitary.
posterior pituitary. The
And the
synthesis
cause?
of ADH. The synthesis of ADH is in the hypothalamus. That's right. You pointed out. That's good. So it can be both, either hypothalamus or posterior pituitary. Okay, but most commonly the problem usually comes from the
Do
posterior.
you know why? Okay, I'm asking why. Why have
Yes.
two places like this? My question. What do you know that?
Good question.
Why we have
The
two
way to
places? We
anatomy.
have one like the hormone. They have the original place to produce that, right? So why for ADH we have two places?
Its synthesis in the hypothalamus, and it was kind of transport to the pituitary.
Pituitary, posterior pituitary for active.
Yeah.
That they produce from the hypothalamus region, and after that they transport or they bring to the posterior pituitary for how to function. They present function in there. That reason why.
Okay,
Even
so
if they have, yeah.
So they synthesize in the supraoptic nucleus of the hypothalamus, and they transport into the posterior pituitary. Okay. So I can explain to you the whole potential things, but that's too complicated. That's neuroscience, completely unrelated to our case. But thank you, Owen, for pointing out that that's very important. That may help you pass the VinMed residency, okay? 'Cause
Oh
Yeah,
my
I
god.
believe
those
so.
tiny details are always important.
Yeah, when we encourage you to apply this, we encourage you and we will support you to do it.
Definitely.
Yeah.
Okay.
Yeah. Thank
Make
you
sure you
so
do
much.
that. Okay. And Vong in the future too. I expect
Yeah.
you to get in there and make everyone proud.
Yeah, we have opportunity, just take it.
Plus, they
Yeah.
pay good. You see that pay? Geez, so competitive. I
Yeah.
bet regular
Yeah, it will
hospital
be
can
really.
pay. Uh-huh. And when you graduate, you can work for them too, which is nice. See, your future is all set. Okay, so let's talk about nephrogenics now. Nephrogenic problem. There's nothing wrong with the pituitary or the hypothalamus. The problem is they don't have the ADH receptor in the descending,
In
the
where?
collecting duct,
Yeah, collecting that. And distal tubular.
and the distal tubule. It's okay. Or they have the receptor, but they don't respond. Something about it. So primary polydipsia, you drink a lot of water. Okay. So if you drink a lot of water, you pee out a lot of water. Makes sense, right? But with primary polydipsia, what do you think about the sodium? You think the sodium will be low or high if you drink a lot of water?
Low.
Low, right? Is this patient sodium low?
No, it's high.
No. Cross D out. So now we end up with B and C. Now here's the problem. B and C is very similar. Okay? So
Yeah.
water deprivation tests will unchanged for both of them. But after you administer vasopressin, one of them will change. What do you think it is?
If it is the reason from the center, it will be changed.
Okay, well, not entirely correct. Okay, if the problem is in the central, if you administer that, it should change. Okay. Now, it's only unchanged when something doesn't work. Okay.
Yeah. The receptor in the tubular.
The receptor in the tubule doesn't work.
Yeah.
Right. So if you administer vasopressin and they don't change, that means the receptor doesn't work and it's a peripheral problem. So it's nephrogenic diabetes insipidus. Vasopressin will change, even though let's say the central problem. I see where you question is. You think it's gonna change, right? Well, it will change. It will change by a lot because it's already changed that much. If you administer vasopressin, the osmolality will change again. Okay.
Mm-hmm.
However, in this case, the nephrogenic diabetes insipidus, if you administer vasopressin, it doesn't work.
Mm-hmm.
That's why we need both of these tests to analyze polyuria.
Mm-hmm.
Okay, because it could be primary polydipsia too. However, with primary polydipsia, what happened after the water deprivation test? Your urine osmolality will go up, isn't it? Because you used to drink a lot of water, then you pee all of that water out, so your urine osmolality go down. Now, if you don't drink any water for 24 hours, do you think your body will try to keep all the water to stay alive? Right? Your body will try to keep all the water to stay alive, so it won't pee out that much. That means your urine osmolality will go up, right?
Mm-hmm.
Does that make sense?
Yeah.
Okay. Anyone have any question or confused? Raise hand, ask. Okay.
So
I look at your face and I can tell if you're confused or not. Okay. So anyone don't understand the issues here with water deprivation test and vasopressin test? Nobody confused. Good. Okay,
I
so
have
what's
a,
the answer? Okay, what's your question?
I just wanna ask about the cause of primary polydipsia.
Okay,
So what?
the cause of primary polydipsia. Usually, usually it's called psychogenic polydipsia. So some psychological issues that make the patient have excessive fluid intake. Okay, could be something affecting the stimulus to drink. Usually schizophrenia can cause it, because schizophrenia may make the patient have the feeling of dry mouth, make they drink more. Okay, but there's too many causes of primary polydipsia. Usually psychogenic is the most common cause, which is schizophrenia or obsessive compulsive disorder, OCD, also a cause of primary polydipsia. Okay, some dipsogenic, which is the abnormal thirst, may be caused by infectious organism like TB, tuberculosis, meningitis can cause primary polydipsia. Sarcoidosis can also cause primary polydipsia. So technically we use primary polydipsia to describe that patient have no other issues and they drink a lot of water. We have to go through the whole algorithm, like hyponatremia algorithm, to determine the cause of primary polydipsia, which brings us to the next case where we have some issues with that. But what's the answer first for this case? Does that answer your question?
Yeah. So
Okay.
the only way to help this patient with primary polydipsia is advise them to go to the psychologist, right?
No, tell them stop drinking water first. Water restriction is the first management of primary polydipsia. Then we find out what's going on. Okay, we have to find the organic cause first before we jump to psychogenic cause. Okay, do not always refer your patient to psychiatry. They will be mad. The psychiatrist will get mad at me if I keep sending everybody to the psychiatry.
Yeah.
Okay. So, but the water deprivation test can definitely tell you if there's a primary polydipsia or not. Okay. What do you think the urine osmolality used to be for primary polydipsia? It will jump by a lot. So if you see urine osmolality jump more than 800 milliosmol, that's usually primary polydipsia. Okay. And they will also change on vasopressin. 5% changes is what we go for. Okay, for central diabetes insipidus, usually you see more than 50% change. All right, so what's the answer?
Yep. Thank you.
What's the answer? Well, we still haven't reached the answer.
The answer is nephrogenic diabetes insipidus.
Okay. Do you know what this patient take? Since this patient has psychiatry disorder, they have to take something. What's the first line treatment for bipolar disorder? Vâng, you know that? Did you learn about bipolar disorder yet?
No, I don't know about it.
Okay, when you go on the psychiatry ward, maybe you will learn about it.
About the
It's very common. Yeah, but the first line treatment for bipolar is what one?
Lithium.
It's kind of
Lithium. Okay. And this question has been asked by many multiple physicians that love to ask this to the student. What's the side effects of lithium? Nephrogenic diabetes insipidus. Okay. That's some common side effects of lithium. Of course, lithium have many other side effects, so you have to watch for it. All right, let's move on to the next case. But bipolar disorder associated with lithium, associated with nephrogenic diabetes insipidus.